Good morning or good evening, good afternoon, wherever you are in the world. We're delighted you've made the time to be able to come with us and join us live. And if you're watching the recording, thank you very much for joining us for our third GTC webinar. So as I said, welcome. This is number 3 in our 2025 series. I'm Amy Freeman-Sanderson, and I'm delighted to be co-moderating this webinar with Sandy Foster, and also on behalf of our president, Dr. Vinciya Pandian. So welcome. Today our topic is transitions of tracheostomy care across settings. For this webinar, again, we're making it very interactive. So if you're listening along and participating and have a question, please pop that in the chat or the Q&A as we go along. I'd also like to acknowledge our sponsors for their unrestricted educational grants. These help support our mission and vision here at the Global Tracheostomy Collaborative of creating multidisciplinary teams with our families at the heart. So we have physicians, nurses, respiratory therapists, speech therapists, and many other disciplines with patients working together to disseminate best practices to improve the outcomes for tracheostomy care. I'd like to acknowledge the country that I'm on. So I'm based on Gadigal country from the Eora Nation here in Sydney, Australia. And I pay my respects to elders past, present and emerging, acknowledging them as the traditional custodians of knowledge for the land. So as always, we love to know where you're from. So please feel free to say hello in the chat and let us know where you're joining us from today. So I'd like to hand over to my co-moderator, Sandy.
Good morning or good evening to everybody. I'm just going to go through the aims of our webinar for today. And the first aim is to discuss the discharge processes for children transitioning from hospital setting and the strategies implemented to reduce the risk of admission. Our second one is to describe the barriers and facilitators for safe and effective transitions of care across different settings, and then to identify and understand the management of risk associated with transitions of care. And our final aim is to understand the physical and emotional burdens of transitions of care from the perspective of the family. We have 3 speakers today who are going to do presentations, and I will introduce each speaker just prior to their presentation. Thank you so much, Evelyn, for presenting for us today. Evelyn is a paediatric nurse practitioner currently working at the Pediatric Clinical Faculty of Rutgers University School of Nursing. She retired from Children's Specialised Acute Rehabilitation Hospital Brain Injury and Chronic Pain Program late last year. She has been in paediatric acute rehabilitation since 2016 and is responsible in assessment, care coordination, discharge planning and management of traumatic and non-traumatic brain injured paediatric patients. She was designated as a safety coach and actively participated in improvement and performance projects. Evelyn is also a wound care APN certified and is involved in pressure injury prevention. Prior to this, Evelyn worked as an APN hospitalist at RWJUH Pediatrics from 2009 until 2016 and worked as a paediatric rheumatology APN from 2005 to 2009. She has been working as an RN for almost 40 years in paediatric, adult, as well as in cardiac open heart ICU. So thank you so much, Evelyn. Hand over to you.
Thank you so much. Before I start with this transition, I would like to define transition of care. Transition of care is support and help for the patient's family and caregivers to transfer them or care to another level of care, and a goal of care meeting their medical, psychological, emotional needs. So before we start with discharge planning, I would like to be able to discharge planning is a critical process where hospital staff develops a personalized plan, assessing a patient's health and social needs prior to their hospital discharge. So before we transition a patient we need to have the discharge planning. Complex children are at high risk for adverse outcomes after discharge difficulties with comprehension and adherence to discharge instructions. Suboptimal transition of care increase the risk of readmissions and adverse drug events after discharge. So what are the goals here? The goals is to improve discharge planning and to reduce readmissions or prevent, if we can prevent, and reduce length of stay. So there's a discharge process that happens once a patient is admitted to the hospital. Acute hospital admission to rehab, there should be a discharge planning, and there should be a decision that will be made if either the patient is going to rehab or home. And there are criteria to be met, like medically cleared or stability of the patient, to rehab, for recovery, for therapies, or for training. It needs a consent from caregiver and a mental assent from the patient. They can start actually education and training at the acute hospital. Then if the decision was made, a consultation should be made to a discharge coordinator, could be a social worker, a case manager, and there should be a specific goal for admission, and insurance process should be started. So if there is a therapy needs, consult the physical therapy for recommendation for therapy. There should be family meeting, answering questions and expectations of the patient or the family or the caregiver, and they should have opportunity to tour the facility. Then order or provide needed non-formulary medications, but not all medications are carried in rehab. Special trach supplies, especially those with congenital anomalies, they need a special mask to go with them. So this has to be provided before the patient goes to rehab. And then confirm insurance approval. Once approval is done, there should be a handoff or a verbal signing off from a sending hospital or provider to the receiving provider. Medical discharge summary should have detailed instructions with specialist phone numbers. And then the patient is transitioned to rehab. So there are barriers for discharge to rehab facility. If patient is very sick, medical complexity is one of them. And sometimes in the rehab, the nurses are very new. They're not competent in the care of very complex patients. There are staffing issues. There's shortage, complex procedures that needed to be done or treatment that needed to be done in the rehab setting. Sometimes you have a difficult family caregiver who is very emotionally or psychologically distressed because of their child being sick and not consenting to transition. And sometimes they have a lack of trust of other providers if they have a recent disappointment from the sending hospital. That would impact their transferring of care. Insurance issues, lack or none, home situation, if there is no home, they live in a shelter. Patients' behavioral, psychological state needing close observation. Sometimes they need one-to-one because they are so agitated or combative. Non-formulary medications, we don't carry sometimes, in the rehab setting, we don't carry those medications and that would delay transfer. Supplies also that are needed would delay transfer, and lack of detailed discharge instructions from the sending hospital, which is very unsafe. So now we're going to discuss rehabilitation to home. This is when the patient is admitted to rehab unit. So we have steps to follow: initial assessment, evaluate, identify needs or assess resources, setting goals, make plans, and implement the plans. So we can discuss one by one in here. So in initial assessment, as we know that discharge planning starts on admission. So this is the time when the patient is admitted to rehab, where we reviewed some medical records and we continue to review medical records. We do the interview process. Initial needs are identified at this time as social, psychological, emotional, and the support system, the patient and the caregiver. We We actually give them a tentative length of stay at this time, depending on their needs. We also want to know the disposition, is it home or facility? And this is the time when they meet or be evaluated by the multidisciplinary team, like the social worker or discharge coordinator, therapy team, medical nursing, respiratory, nutrition, child life, and even psychology therapy. So in evaluate transitional needs, this is the medical diagnosis complexity and treatment regimen. Is the diagnosis very clear? Is the patient or family accepting the diagnosis? And also in continuity of care, we have to know what the patient is needing to go home with. Are they needing a trach, a vent? What are the medications, supplies that they need? This is early on the admission process. Patient caregiver education readiness. Are the parents or caregiver ready to receive education? And what are the barriers to training? Do they have a transportation? Health literacy, language barrier. Family caregiver cooperation in discharge planning. This is also important, and you can utilize a discharge pathway at this time. Then we need to set goals. Sometimes the family goal is in disagreement with the team goal. So we need to have a clear discharge criteria. And a priority is safety for every patient. Identify problems and barriers. We need an ongoing updates during this time. We do weekly family meetings and also a meeting within the week, not even once a week, maybe in a few days. Depends on what the barriers are identified. And the length of stay, we revise as needed. Plans. So when we make plans, we do medical plans. If the patient is vented, so do we need to wean them, the ventilator settings? We have to switch into portable home vent. Do we need a trach for home? Do we need all the medications? We need to wean them, discontinue some meds. Then we have to start coordinating with the ongoing training or education with the nursing. There's a nursing educator that is responsible for educating them with a trach. Therapy education, confirm needs, supplies, DMEs, confirm the need for home care nursing, nurses aid to help the family if they're not, if no home care nursing is not available. Identify other patient caregiver support system. We need 2 caregivers for trach patients to be trained. Arrange family transportation for training and insurance approvals for medication and DMEs and home care nursing. We have to implement the plan. So in this time, sometimes referrals are made to long-term care. Sometimes dual planning is needed because initially the family is not ready for home to bring the patient home. So we do dual referral for disposition. So we also order supplies at this time and all the DMEs, follow-up insurance approvals for those supplies and DMEs, complete patient and care education and training, home care, VNA needs, and other needs like wound care. If they have wounds, communicate and schedule specialists, follow-up appointments, and also call the specialist if they need to follow up the patient as soon as possible after discharge from the rehab. Ongoing patient caregiver updates of discharge instructions, revised plans as needed, use of the discharge checklist, which is really important not to miss anything that the patient needs. Referral to pharmacy, we do give counseling and education for medications. There is a good acronym for discharge, IDEAL, ideal. I includes patient caregiver as partners in the discharge process, which is huge for them to cooperate. Discuss diagnosis, educate, assess how well diagnosis was explained, discharge process, next steps, listen to patient caregivers, family goals and preferences, their concerns and their observations. What are the discharge barriers once they are in rehab? Poor communication from sending facility, delayed identification of needs. There is lack of collaboration. There is no role clarity of who's the discharge coordinator will be. A patient caregiver, what their emotional state or psychological state will be, discharge readiness. They have fear of changing trachs, for example, lack of support in the family if they're divorcing, lack of experience in caring for complex medical patients, discharge instructions, complexity, lack of insurance, delayed application, no approvals of medication DMEs, lack of no disposition, home inaccessibility, lack of provider specialist appointments, and also to add here is the home care nurse, competency of home care nursing, and also their availability. Night shift is a problem. Education and training readiness. There is poor communication strategies for teaching, like hands-on, language barrier, and health literacy. We can use discharge checklist. This is just an example. It should be like a teach back. Whatever they learn, they can teach back the provider or the nurse. So check that they understood what they were taught. We use discharge packets where the information, teaching, education, therapies, needed appointments, phone numbers of specialists should be there. And this is also an example of a checklist before a patient is discharged. This is for providers, for care coordinators. In summary, before discharge to be considered, look at the language barrier, health literacy level, autonomy, independence of the patient if they're functional or ambulatory, components of discharge instructions, diagnosis, prognosis, follow-up, when to go to ER, when to call the provider, and who the provider needs that needs to be called in case of emergency. To improve the DC process, we need a written detailed discharge instructions, education training, collaboration with the healthcare team. And also in our rehab, we call the family, especially the complex patients, in 2 days after discharge, or sometimes in a week for less medically complex patients, to just check if they're okay, no issues. Prevent readmissions, we need effective discharge planning and coordination amongst the team, effective communication, integrated care and seamless communication among specialists, utilize teach-back method education, competent use of equipments. They need to learn how to use the equipments before they go home, especially ventilator and some feeding pumps, correct medication with the caregiver. This is also huge. So that's why they need to receive pharmacy education before going home. I think this is it. Thank you.
Thank you so much, Evelyn. I think this really highlights the importance of discharging planning starting early, and also identifying the discharge barriers and involving healthcare professionals and families so that everyone is on the same page. Next, I would like to introduce Dr. Brandon Hopkins. He is a board-certified pediatric otolaryngologist at the Cleveland Clinic's Head and Neck Institute, where he has practiced since 2013. He serves as a surgical director of the Pediatric Centre for Airway, Voice and Swallowing. And he's the clinic's aerodigestive program, with a clinical focus on complex airway and swallowing disorders. Dr. Hopkins also served for several years as Vice Chair of Safety, Quality and Patient Experience at the Cleveland Clinic. He completed his fellowship in pediatric otolaryngology, cleft and craniofacial care at the University of California, Davis, and his residency at the University of Cincinnati and Cincinnati's Children's Hospital. Thank you so much.
Thanks, Sandy. First of all, it's a pleasure to be here talking to everybody from around the globe. I'm realizing all the places I need to visit that I have not yet visited, and realizing I need to trim that bio a little bit. So thank you guys for having me. I think really, I'm one of the members of the aerodigestive program here, and that kind of warm handoff team once children leave the hospital or the rehab facility. But I think all of these issues start way before they leave the hospital, even before they get to my hands, even before I place a tracheostomy. So I think we really focus a lot, and I'd recommend honesty, transparency, early, consistently. However we can do that from day zero, I think frame sets for the rest of these families' lives. Because we know that placing a trach is huge. You know, if these families, you know, there's tons of decisional regret. A lot of families feel uninformed after a tracheostomy, and there's nothing worse than trying to play catch up, right? You know, your first introduction, it takes 7 times meeting somebody to make a bad impression better, right? So let's do this from beginning. We know quality of life scores are low. I think Evelyn hinted at this. A lot of families leave the hospital with utilization, with instructions and kind of not understanding things. We know that, you know, there's a lot of distress, a lot of mental health issues, and a lot of my practice, you know, I don't think we got a lot of objective data out there, but this is really hard on families. This is really hard on couples, and figuring out how to help families with these issues is super important. So we meet these families early before the tracheostomy is placed. We start talking about these airway issues early. Multidisciplinary teams with the neonatal teams, all of our pediatric colleagues, palliative care, our bioethics teams. We share operative photos, we share imaging, and we really work towards emotional intelligence as early as we can. And I think we had some questions on here a little bit about literacy barriers and health and language barriers. I think that's a struggle. I don't know if I have an answer, but you know, we're incorporating AI more and more into kind of language, especially with translating some of our instructions, trying to meet these families where they're at. But knowing what those family factors in, I think, you know, in the past, when I first started surgery, we would place a trach and then deal with these issues afterwards. Now, 90% of what we do is preparing families to understand what it's like to have a trach. What is the disease process? What is the swallowing potential? What is the speech potential? What is the neurologic status of their family member going to be long term? What type of interactions are they going to have with the world? Can we hear? Can we not hear? How do we just kind of prepare them? And I think we also mentioned a little bit earlier the struggles that we know families are going to have. We know if you're going to have a ventilator at home, obtaining that home nursing support, especially 24 hours a day, I'm sure is a struggle throughout the world. I know in the United States, it is very hard to get 24-hour nursing now. And if you only have one caregiver at home, we really have a hard time getting you home from a rehab hospital. If you don't have more than 2 caregivers at home, or at least 2 caregivers that can take care of a trach, a lot of these children can end up in limbo a little bit. And knowing what a family's quality of life means. What does it mean to them? What are they trying to achieve with this relationship with the patient or their child? What would be a win? You know, what do they look at as a win moving forward? So that's kind of where we do before we place the tracheostomy, I think, to grease the wheels for all these transitions in the future. And then once they reach us, once they leave rehab facility or once they leave the hospital, our aerodigestive team tries to maximize quality of life, avoid hospital visits, emergency care visits, and really facilitate that navigation of a complex care system. I don't care where you're at in the world, these problems are the same. These are complex kids with multiple different providers with really complex needs. And again, with families with different level of healthcare understanding, different level of language understanding. And if there's not a quarterback that's helping families along, this can be a struggle, especially for those with lower health literacy. We know that after you get out of the hospital, lots of people are going to end up in the emergency room, lots of unplanned visits. And I think the data is pretty clear as well, is that these are hugely costly visits for the healthcare systems. In the United States, you can just see the highlighted areas here. 1 to 2 hospital stays, a $35,000 bill on average across the United States for tracheostomies. For a 2-day hospital stay, $70,000. And these numbers can be exponentially larger when it's a tragic unplanned event, whether it's a plug or whether you're needing a big surgical procedure, as can be visualized by like the length of stay of 1 day when these families come in a crash situation. You know, we want to do everything we can as a community and an aerodigestive team to minimize these issues. So how do we do that in Cleveland? You know, we have an aerodigestive program. I think many of you are familiar with these, where we have a care coordinator, team-driven approach. with our focus on the individualized care plan. And I want to harp on that because that's our source of truth. I think that's what minimizes these transition issues for families, is having a source of truth for everybody and trying to plan ahead so we minimize all these issues. You know, we have virtual clinics, we do inpatient rounding, and inpatient rounding I think is also key because that's the warm handoff from the hospital to the rehab facility, and then from the outpatient setting to the inpatient setting. That inpatient rounding team that is mirrored with the aerodigestive team is super key. And I'd like to say this is me doing all these things, but these are the people that make my world work and make my patient's world work. We have my nurse practitioner, our care coordinator, and Christine Arnica, who is our social worker. And I can't stress enough how much social work like drives the boat in these situations for successful families. And again, like I said, this is what we do. You know, we have a clinical abstract, we have that source of truth, which one, makes sure there's an ongoing plan of care as these children progress through life. Sometimes it's an airway focus, sometimes it's a cardiac focus. That source of truth helps with that. It helps with figuring out frame setting. Every time we talk to family, what is your quality of life? What is quality of life to you? Because for me, maybe decannulation is quality of life, but maybe for family, it's how do we get my child with a trach speaking? You know, my child, you know, we want to be able to communicate, or we want to be able to feed. What does quality of life mean for you? And really minimizing those unplanned admissions, not just for the family, but for the healthcare system. If we're spending $40,000 on a readmission for every time they go in, and we can decrease, you know, instead of 5 a year, they can have 1 a year. That's a huge healthcare savings for the patient and for the healthcare system. And you know, this isn't details that need to kind of go over for each of this, but I wanted to give an example of what our abstract looks like, what our source of truth looks like. You know, we have our history, we have all our individual providers that are on our aerodigestive team, that kind of specific questions for the families. You know, what was our plan last time? What was the hospital and the medical kind of resource utilization that the families have had since our last visit? How many times they've been hospitalized? Why were they hospitalized? What's the social work plan? What is the home care equipment? What's their swallow status? What's their hearing status? You know, what was their last airway evaluation, and what home care therapies do they have? You know, I think this is a ton of information. It's even hard to digest when it's in a very formatted way. But I think having this for the families, having this be their kind of source of truth as we change things over time, whether it's their ventilator settings, whether it's their tracheostomies, I think being able to update one thing over time where everybody can see can really be helpful. And this helps a couple things. One, it helps, you know, identify landmines. What is the thing that the family is really struggling with? We may worry about their trach, but social work has identified that the family's about to get their power shut off and they don't know what's going to happen from a ventilator standpoint. So if we can identify that ahead of time, we can keep that from happening. We can write letters to the electric company to get that delayed, or get a passionate exemption for them. What are the stress points for their life? I think we mentioned a little bit earlier about supply chain issues, about nursing, about these kind of issues that are having. But then empowering the families that they kind of own this abstract. They own this source of truth. My families that are most successful about achieving their goals are the ones who don't let us drive the boat, but are like engaged in that care and can be active participants in their abstract and point out, they're like, oh, well, you know, actually the modified barium swallow was here, or, you know, that dynamic conversation back and forth with them is really important. And I think with regard to transitions, there's two types in my mind: unplanned admissions and planned admissions. And I think trying to minimize both of them is very important. I think all of us want to partner with our local emergency providers so they know what to do when they show up with somebody's house with a tracheostomy when an emergency is called. We want to have family understand, have some ownership in, you know, how do you obtain an airway? Can my child be intubated from above? And that way they can kind of also give that warm handoff to the emergency providers or to the emergency room if they show up somewhere. Again, inpatient rounding when we're in the hospital, and then have that inpatient rounding team be involved in warm handoffs once they leave the hospital. So again, we can smooth that transition back to the post-op visit and either a virtual visit or an in-team visit after they leave the hospital. And then I think the last thing is really planned admissions. And our team focuses on this astronomically, where when can we anticipate that something's going to happen, that we can coordinate care, whether it's multidisciplinary operative procedures or whether it's admissions for ventilator management, transitions off the ventilator, and we can combine things to keep a family from ending up in the emergency department so we don't have those catastrophic events. If we can combine things and like kind of ward off evil spirits by intervening early, I think we're much more successful. And I think really our focus on combined hospital procedures, we've shown from numbers wise that we can decrease the number of anesthetics, we can decrease the minute of anesthetics when we combine our procedures, whether that's the traditional triple scope with a airway evaluation by ENT, pulm, and GI, but also with other things when you're talking about ABRs, sedated hearing testings, MRIs, ophthalmology exams. All of these things can be coordinated. Like, for instance, tomorrow my aerodigestive OR is tomorrow on Friday, and I think I have 7 different patients we're doing, but we have 10 different providers in my operating theater from a coordination standpoint, just so those families don't have to come back 3 or 4 times to the operating theater. Because every time you hit a hospital setting, it's more likely to have a complication, more likely to have a hospital-acquired infection. All these things are what we're keeping in the back of our mind. So again, just to reiterate, to close, we want to maximize quality of life. I want to avoid unplanned hospital visits, and then plan the ones that we can do to coordinate care and decrease multiple needed visits to the hospital while just smoothing out the kind of complex care for these families. So again, appreciate your guys' time and happy to take questions at the end.
Great, thank you so much. And I agree with you, tracheostomy is a big deal, and having those conversations with parents is really, really important. I'm going to introduce Zoe now. Zoe is a mum from Melbourne. She's a full-time carer to her young daughter, Sophia, who's had a tracheostomy and uses BiPAP ventilation, and that's related to congenital myasthenia syndrome. Zoe has first-hand experience navigating prolonged hospital admissions, intensive training in tracheostomy care, and the challenges of transitioning home. Zoe is passionate about advocating for safer and more supported hospital-to-home transitions and improving collaborative between families and healthcare teams.
Thank you,
Zoe.
Sandy. As Sandy said, my name is Zoe, and this is my daughter, Sophia. Sophia was born in April 2024 in Melbourne, Australia, and she's under the care of Monash Children's Hospital. At 7 weeks old, she was diagnosed with congenital myasthenic syndrome. Her main ongoing issue has been chronic respiratory failure, and despite trials of high-flow nasal prongs, non-invasive ventilation, Sophia experienced multiple apneas requiring resuscitation, which led to her tracheostomy being placed in October 2024. And now she has a tracheostomy and she uses BiPAP ventilation during sleep. She spent a total of 10 months in hospital, and since her final discharge in January 2025, we have not had any unplanned or emergency readmissions. So before Sophia's tracheostomy surgery, we had already been in the hospital system for about 5 months. So luckily we had a really good understanding of the medical terminology that was being used. We already knew the teams that were involved in her care, and I think this was a real benefit for us. And because the surgery was planned, we had a few weeks to prepare with Sandy, who is the tracheostomy CNC at our hospital, and we were able to understand what tracheostomy care would look like. We were able to visualize all of the different pieces on the tracheostomy training doll. We were able to speak to speech therapy and clinical education about what that kind of care would look like, what in-home nursing would look like for us, and that kind of thing. Before her discharge, both my husband and I had to be signed off on a list of competencies, including 3 unassisted tracheostomy tie changes, 1 unassisted tracheostomy tube change, ventilation training, tracheostomy-specific basic life support training, and enteral feeding. With the training, it was very hands-on. So every day before doing Sophia's trach care, we would organise a time for a clinical educator or PICU outreach nurse to come to the ward and supervise whatever care we were doing that day. And then once we were signed off, we were able to do that daily trach care on our own. We also had access to the tracheostomy training doll. We could request to keep it in Sophia's room so we could practice on it in our own time. And once we were signed off on every aspect of her care, we also had permission to leave the ward on our own with Sophia, which I think improved our confidence a lot by the time we were discharged. We prepared at home, so we purchased a pediatric hospital cot for her safety, organising storage and medical equipment, and also just preparing our home not only to be safe for her, but also to become a workplace for all of her in-home supports. In Australia, we have the NDIS, which is National Disability Insurance Scheme, and it supports funding for therapy, consumables, assistive technology, and in-home care. And this is ultimately what delayed our discharge so much, because we didn't have approved funding for in-home care yet. And so we couldn't be discharged home safely without it. We put an emergency management plan in place, which covered things like Brandon mentioned about power outages, hospital readmission procedures, illness, accidental decannulation, and also escalation protocols. So the plan clearly outlines who to call when do we contact our clinical nurse consultant versus an ambulance, what signs to look for that she's deteriorating, who is available after hours and during business hours, and what numbers to call. And then we also set up an ambulance alert for our home address so that if we call for emergency services, a specialist ambulance is dispatched. Our exact discharge date was set about 2 months prior, and from that point we had fortnightly family meetings with her entire care team, so respiratory consultants, allied health, social work, to coordinate planning. And alongside those family meetings, we were also heavily involved in daily rounds. Towards the end of her discharge, Sophia's medical team arranged a step down for us to a children's hospice and respite facility where she stayed for 5 weeks post-hospital discharge. And this step down was essential for us to increase our confidence and training in a less acute but still supported environment. In Australia, we have access to a complex care program which aims to coordinate multidisciplinary care across hospital, outpatient, home settings for children with complex needs. So we were referred to them pretty early on in Sophia's journey. We have been assigned our own clinical nurse consultant, our own social worker. We have funding for 24 hours a week of in-home care through complex care, and our monthly consumables are also funded through them as well. One of the most helpful things that our complex care nurse has done is we have a document called Sophia's About Me, and it includes everything like her emergency management plans, feeding plans, troubleshooting guides on every single piece of equipment, so suction, ventilators, everything. Documents outlining what equipment needs to be changed when, how do you clean her tracheostomy tube, and all of that practical stuff that you need at home. We use it almost every day, and it's also a really good tool for our in-home care workers to use as well. Complex care also handles all the training and assessment of our in-home care workers, and beyond the training, they remain actively involved with attending outpatient appointments, conducting home visits, and in the future they can help with logistics like alerting the hospital if Sophia is going to be attending the emergency department. In terms of clinical training requirements versus our experience, I think there's a big gap between what's expected of us and where we are emotionally during that time. Unlike medical staff, we can't separate our work from what we're doing because we're performing these life-saving procedures on our own child, and that's really overwhelming, and it takes months to feel confident. I still remember when I did my very first tracheostomy change on Sophia, and as soon as the tube was secured, I turned to our PICU outreach nurse and I burst into tears. And she actually told me that that reaction was quite common from parents doing that for the first time, but no one had ever mentioned that to us before, so it was really unexpected. that emotional weight impacts our ability to learn, our ability to feel confident and to stay mentally well. And I think families need more emotional support because the goal is not just to get home, but it's to stay home. And if you send families home emotionally disheveled, they're only just going to present back pretty soon. Another thing that I guess wasn't at the forefront of our discharge planning or even really mentioned was just the expenses that we were incurring on that long hospital admission. So in Australia, we're lucky that all of her direct medical care was covered, but I had to stop working to become Sophia's full-time carer, and my husband reduced his hours to only 20 hours a week for the first year of her life. And one of the largest unexpected expenses was hospital parking. And over the course of our admission, we spent over $3,000 on parking, despite input from social work and asking for any assistance that we could get. So what worked well? Despite the challenges, several aspects of Sophia's care and transition went well. So the complex care program provided coordinated, consistent team that supported us through our admission and then discharge process, and still now. Our multidisciplinary approach ensured that all of our medical, nursing, allied health and social work teams were collaborating. We had aligned goals. And because of the approach, we knew that the multidisciplinary approach, we knew that the admission would be so lengthy. So we actually were able to arrange for her GJ tube to be placed on the same admission to save us from being discharged and then having to come back to the hospital later. What else worked well? We were encouraged to have hands-on care as soon as we were able to. So as soon as she was stabilized after surgery, our training began straight away. And I think the early exposure is what helped build our confidence and skills. But because we had such a lengthy admission, we did also have time to adjust. We could revisit things, ask questions, and somewhat learn at our own pace. Family involvement was the center of our discharge planning because I think you have to take into consideration every family's unique circumstances. At the same time Sophia was in hospital, I was going through breast cancer treatment, and that was really important in our discharge planning because we had to not only take into consideration her care, but how was her care going to be provided at home, and were we capable at that time? Also, the step down period that we had at the Children's Hospice was invaluable. Once we left the Children's Hospice, so we were there for 5 weeks, the hospital still facilitated hospital in the home visits for us. And we did that every single day for 2 weeks to ensure that we were settling in, and we also still had immediate access to her medical team during that hospital in the home process. Post-discharge, knowing that we had our complex care nurse to fall back on took a lot of pressure off of us. And the ongoing relationship is really what's bridged the gap between hospital and home, and will also bridge the gap between home and hospital if and when we do eventually have to return. So what could be improved? Navigating financial supports, NDIS and Centrelink was very complex and very overwhelming. And I would consider considering NDIS approval was crucial for us to go home. We were kind of almost left on our own to navigate that, and it was really difficult. So I think having early dedicated guidance would have eased the burden. Discharge criteria and timelines were not communicated as early as they could be, I think, and they led to things being rushed through at the last minute. Even though we had planned the discharge about 2 months in advance, I think everyone gets caught up in how long you've been there and thinking that you're not going to run out of time. And so there were things that we were doing on the day and the second last day before we were discharged that I think could have been arranged a lot sooner. Oxygen tank deliveries, consumable orders, and things like that. Considering that there probably by now has been so many families that have gone through this exact process, there could be almost a step-by-step tick box.
My friend is doing a speech about tracheostomy with doctors and stuff.
Is this the one?
Emotional support for the family needs greater emphasis. So regular mental health check-ins and counselling, I think, should be standard during long admissions. I don't think the family should have to reach out and ask for that. They should be given it. Because we were across multiple wards and we had actually gone home before tracheostomy, we were bounced around between different social work departments. We were able to form a relationship with our complex care social worker once we had gone home. But once we returned back to the hospital, we were shifted back to the ward social worker and we had no continuity of care. And by the end, social work didn't make a lasting impact on our journey because we didn't have that continuity of care. I think peer support should also be embedded into care plans because it makes a huge difference having social and emotional connection during long admissions. Even just meeting another family who had gone through something similar could have helped us better understand what life might look like once we were home. The discharge was very emotional for us. We were excited to bring Sophia home, but at the same time, it was also really scary. And I think this is something that our medical team and nursing staff didn't quite understand because everyone expects you to just be really excited. But after you've been in the hospital for so long, it's actually just really nerve-wracking because you're leaving all of the supports and all of the relationships that you've built along the way. The practical challenges started straight away. We had never had to manage the equipment schedule or ordering consumables ourselves. I think the focus is on how to do tracheostomy care and how to use a ventilator, but not so much focused on learning the practical side of things, like what is disposable and what is reusable, what gets changed when, and how often you should be ordering things. Within the first week of Sophia being discharged, she had her first emergency tracheostomy change. And after only ever talking about what you would do in an emergency, it was really different actually having to spring into action and do it. We also didn't have full in-home support after discharge for quite a few months. And ideally, that kind of care would be organised well before the discharge date and not after. It's taken us 6 months to get systems in place that actually work for our family in terms of medical storage and that kind of thing. And essentially turning your home into a functioning medical facility isn't something that you can do overnight, especially when we didn't have a peer support group to lean on or learn from. And I think that task in itself is hugely overlooked by medical teams. Since we brought Sophia home, she hasn't had any unplanned hospital admissions. And I think that comes down to a few things. The hospital gave us a strong foundation. Hands-on training and support meant that we felt confident in her care before we left. We learned how to recognise her baseline, which helps us know when something's off, but it also means that we're not panicking unnecessarily and we don't delay when urgent help is needed because we know the difference. Continuity of care via complex care is the best win in cases like ours. The immediate access to advice, practical and emotional, makes a huge difference in easing our anxiety, especially in those early weeks. Regular check-ins from her medical team, often via telehealth, have helped us stay on top of her care without constant trips back to the hospital, especially now during winter. If we do have to go in, like Brandon said, you can combine procedures. And so, for example, last month, we needed both a sleep study and a bronchoscopy. We were able to do the sleep study the night before and go in straight away for the bronchoscopy in the morning. I think our experience shows that a safe, successful transition isn't just about the clinical readiness of the child, but families also need emotional support, clear communication, practical help, and real continuity of care across every setting. Thank you.
Thank you so much, Zoe. I think sometimes we really do need to pause and remember the emotional support for families is just as important as the practical tasks to focus on before discharge planning. I'll hand over now to Amy.
Thank you. And I think you've got control, Zoe. So we're just moving across. Thank you so much for all of the panelists and your presentations. We've got an opportunity for a panel discussion. So We'll do, I've got a couple of questions to launch off with, and also inviting Sandy to our panel. A lot of you, all of you spoke really at the theme of understanding what families need at different points in time. So the practical aspects and the emotional aspects, that was really sort of prominent across all of your presentations. And I'm just wondering from all of you, and I'll ask you all separately, perhaps Zoe, I'll come to you first, and then Brandon, how can we best identify and hear from family about their concerns? So what mechanism can we do to really optimize and hear and make space for families to raise their concerns? So Zoe, if you could maybe launch off around what mechanisms worked well for you and your family.
I think what Brandon was saying earlier about talking about those things as early as possible in the piece. So like I said when I was speaking, Sophia's tracheostomy surgery was planned, so we had a couple of weeks beforehand, but we had been in hospital for months before that and talking about that as a potential possibility. I think it's obviously different if you're in an emergency situation, but talking about those things as early as possible and identifying not only the tracheostomy care, but what other areas are the family going to struggle with? Do they have support from other, wider family members that could help? Do they have anybody else that can be trained in her care? What are they going to do in an emergency situation? Do they have other children? How far away are they to the hospital? And, I think social work input at that point is really important to learn what else the family is dealing with, and making sure that they understand what the care is actually going to look like. Because I think even for us, we were so well prepared. We had a really good understanding of what it was going to look like, and it was still shocking to us. So I think that's really important as well.
Brandon, your sort of thoughts and mechanisms that have worked really well for you and your team.
Yeah, no, these are super hard situations. I mean, every patient's different, but I think I would go back to the tenet of trying to be honest and transparent with families, letting them know the things we can help with, and then being honest and being like, there's limitations to what we can provide and limitations to what we can do, but trying to be nimble and dynamic where you can't always fix every problem and everything that comes to the door, but you can try to take one or two things off the plate for this family, or what is the primary concern that we can kind of move the needle forward for you today or during this visit. So just trying to be a partner and a collaborator with them, from a team approach, and trying to remain, my superpower is I'm sympathetic. I'm not as empathetic as I could be. So making sure you have people on your team that can be those empathetic voices and can meet families better, where you're at, as opposed to a surgeon approach, which sometimes we have.
Thanks. Evelyn and Sandy, did you have anything specific from your facilities and experiences about really creating that space along the continuum for to check in with families and understand their needs? So Evelyn, I can see you're off mute. You go ahead first.
Yeah, I muted myself. Unmuted. Yeah, I agree with Brandon and Zoe. Yeah, early conversation is very beneficial for this family to prepare them, and what expectations and what are the maybe barriers, or maybe what they need to learn in the process. And that would really prepare them, because information is huge, and parents and caregivers really needed that information, what to expect. Most of the time, it's always a problem when they are in rehab setting, because they're not as prepared or informed of the expectations after a tracheostomy and what needs to be done for home. So yeah, I agree.
And I also think it's about asking the right questions to families as well, making sure that, you've touched base with them and say, look, how are you going? Where are you at? Are really important questions to ask them.
it's also true in a rehab setting. I always ask the question, what did you learn, or what were told her or told him, the parents, or what was communicated to them? Learning what they learned first, then I could add on it, you know. So it's true, Sandy. Right, asking the right questions. Or what are their questions, further questions?
And I guess this sort of links with one of the questions that we've had from one of our audience members, Catherine, around then linking that to digital touch points. And I suppose how we coordinate that as a team in terms of digital touch points to for families to sort of be able to communicate effectively with on-call providers. So Zoe, you sort of really highlighted some of the aspects of you know, during the day and the night, and Brandon spoke about those different you know, different time points of care. So can any of the panel members speak to any experience with digital touch points, either for healthcare team or family, around how we sort of centralize these communication points?
Yeah, I mean, I think we actively use MyChart messages through Epic. I mean, I think our healthcare delivery system is Epic, our electronic medical record. And through our MyChart messages now we can send videos and photos. So I think that's been a huge win to, like, what does your child sound like? What does the stoma look like? It's just made that communication a little smoother, and then making sure there is a pool that gets sent to. So, you know, if it gets sent to our care coordinator, then she will or he will direct it to which of the teams it's most appropriate, whether it's GI, Pulm, ENT, physical medicine, rehabilitation, who's the point person for that. That's how we've used kind of digital tools, I guess. We'd love more, I guess.
And we don't have anything like that, but we do have complex care. So I just text or email her or call her or Sandy. We can send photos, we can send videos, and luckily Sandy, Tracheostomy CNC, sits on the same team as Sophia's main consultant, respiratory. So they can just have a pretty casual conversation together. But then also for after hours, complex care has an after hours number that we can call. Or I don't know how many patients, but definitely complex patients like us, we have the direct phone number for the respiratory consultant on call. So we can call them at any time. I've never done that because I'd be mortified if I called someone on call at 2 o'clock in the morning. But we can if we need to, and we can call if we're ever en route in emergency and just let them know that we're coming.
Yes, and I agree. So I'd love to have more digital access, but the other thing we can do is telehealth as well, which we do utilise ad hoc if we need to.
Yeah, and I think, you know, it will be sort of seeing the increase of that and looking at what families need, and I guess really to summarise, it's that point of empowerment that everyone's spoken about. How do we, what does empowerment mean to individuals, families, and taking your words, Brandon, what does a win look like, and making it individual to that family about what they need. I'm mindful of the time, and there's lots of comments coming up in the chat, so I just wanted to acknowledge the audience about putting those questions in as well. We will get a copy of all the chat and reach out to you afterwards as well. But there's lots of thanks and gratefulness for the wisdom shared by all the panelists.
And Amy, I see a very specific question. I was going to answer that.
About
the gel pad or a flex seal. You know, we've struggled with that as well. I do know, and we just recently reached out, Bivona, again, I'm not married to any tracheostomy brand, but Bivona has on their customized tracheostomy order set, like you can just Google Bivona custom trach. They have an option where you can put a stomal seal below the flange of the tracheostomy tube. It can be foam or it can be silicone, and it can be tapered or it can be straight, you know, so you can kind of customize what interaction below the flange has with the stomal site for people who have a large leak or you want to seal that area off, which I think would probably work similar to that Siliflex gel that you mentioned. Apologies.
No, thank you. Please don't apologize. Wanted to sort of acknowledge the next webinar is in December. So that will be webinar number 4, our final for the year, which will be on Thursday, December the 4th. So to find out more, please keep posted on the GTS website, and also email blasts will be sent out. So just to finish up the webinar, I'd like to hand over to our President, Dr. Vinciya Pandian.
Thank you, Amy. And thanks to everyone for joining today's powerful session on transitions in tracheostomy care. I want to use this moment to invite you to the 9th International Tracheostomy Symposium, which is going to be occurring on October 23rd and 24th at the University of Chicago. This year's theme is Excellence in Collaborative Tracheostomy Care from Hospital to Home. So it's going to be carrying the same message that we've been discussing today, but in a broader scale. And it really is going to celebrate our global interprofessional community. So we have 2 full days of cutting-edge science, hands-on workshops, and real-world innovations with parallel tracks for pediatric and adult care teams. We also have a track specific for individuals with a tracheostomy, families, and caregivers. And so whether you're a clinician, researcher, caregiver, or someone with the lived experience, this is your space to learn, connect, and lead the future of tracheostomy care. So join us as we collaborate across disciplines and borders to elevate safety, outcomes, and quality of life for all. Registration is open now, so go to www.globaltrach.org. So please don't miss it. We truly hope to see you all there. And before we close, I want to sincerely thank today's incredible speakers again, Evelyn David, Brandon Hopkins, and Zoe Chung for sharing your expertise and heartfelt perspectives. And to our moderators, Amy, Freeman-Sanderson, and Sandy Foster, thank you for skillfully guiding today's conversation. This session has highlighted an important truth. Safe transitions of care don't happen by chance. They happen by design. So through interprofessional collaboration, early planning, clear, honest, and transparent communication that we heard over and over, and honoring the voices of families, we can make every care transition safer, smoother, and more human. And so to all our attendees across the globe, thank you for your time, your questions, and your continued dedication to this vital work. So on behalf of Global Tracheostomy Collaborative, please stay tuned for future webinars, and don't forget to register for the symposium. So until then, take care, stay connected, and goodbye for now.